You are listening to the Business Samurai Podcast. Growing a business is hard work. The faster you grow, the harder it is to keep yourself on the right path. Welcome to the Business Samurai Podcast, where we break down the fundamental skills necessary to become a well-rounded leader as you continue to conquer the world in your business. The best business-related podcast as you captain your own destiny and rise above the noise. To help your growth strategy in simple terms you will understand. You will learn the best metrics to track, how communication is the lifesaver when it comes to business, and how good policy will fix the weak link when it comes to cybersecurity. People. Listen in on conversations with world-class business leaders and how they manage growth and integrate the latest technology. We will deconstruct their processes on how they choose to advance themselves, their team, and customers. You are stepping into a world of proactive business with your host, John Barker. Welcome to the Business Samurai Podcast. I'm your host, John Barker. Got another fantastic episode today. Got Dr. Sybil Ingram. She's a successful and respected governance, management, and technology professional with significant expertise with various information security and quality audits and assessments, domestically and internationally. Specialized in quality management systems, risk management, privacy security challenges, and information system solutions. With over 20 years of professional experience, she is one of the nation's foremost champions and active consultants for the HIPAA regulations and implementation challenges. She has held key positions with industry leaders such as iPatient Access, McKesson, Johnson & Johnson, Abbott Laboratories Boston Scientific, Amgen, and the Centers for Disease Control and Prevention, the CDC. In addition, Dr. Ingram is nationally board certified by the American Society of Clinical Pathologists, a member of the International Scientific and Engineering Society. She is an inventor and held a patent pending with the United States Patent and Trademark Office. She has a PhD in health science and medical ethics, MBA in information systems program management, and a BA in medical technologies. Dr. Ingram, that is a very impressive resume, and thank you for taking the time to talk to me today.
Not a problem, John. I'm blushing, and I know you really can't tell, but whenever somebody reads my bio, part of me says, yes, I actually did that.
You did all that stuff. Exactly.
And it's just, I'm flattered that you would have me on your show. Number one. Number two, I wish you much success with this endeavor. And I'm going to definitely try to make it worth your while to invite me to be with you on your show today.
No, I appreciate it. For everyone listening, or if you happen to watch any of this on the YouTube channel, first met Dr. Ingram on a project that we did volunteer for the Cybersecurity Forum Initiative a little over a year ago. We worked on it for about 3 months. Yeah. And it's actually where I kind of wanted to start kind of a jumping off point before we go into HIPAA and privacy and all the stuff that your career has basically been around, because I felt like the CSFI project that we worked on information warfare is relevant to current events as we're currently recording this right now in March of 2022. You've got the Russia invading Ukraine. Mm-hmm. And a lot, I know there was other subsets of our team members that I think actually focused specifically on those areas. I know I was on China and Taiwan and the relationship with there, but how information, misinformation, disinformation really, affects perspective and in the world. So I kind of want to get your take after you went through that. You were, I believe, the overall project manager for that program and had a lot more visibility to the whole thing, but get your thoughts on what you learned during that experience, working that project to current events today.
Well, yes, now we don't want to be remiss in terms of mentioning Abby Dites with CSF. She was the project management liaison between us and our team, as well as with CFSI, excuse me. And that was one of the most exciting projects, even though I pulled out some of my locks in the process of working on that I've ever worked on in my life. The content, the subject matter was very informative. It was very timely. I believe at one point we had about 22 people on our team.
Sounds about right.
Would come and go, based on what we needed at the project at that particular time, the subject matter expertise that we needed for different countries, for different nation states. for different technologies that the different nation states could potentially use in order to siphon off information from another nation state, or just and we did a little bit of a dive into the dark hat world with hackers and what hackers could do, and how that information could be used in nefarious ways against other countries, and how governments were going to be getting into the use of the information if they were privy to it. We could look at some of the ABC agencies and here, as well as the ABC agencies that they have in other countries that are counterparts to ours, and how they would use that information. So, with our team being a domestic team as well as an international team, because we had people in Nigeria, Amsterdam, we had people in Spain, we had people in Greece, I believe, all the different.
There's somebody in France on ours.
Yeah. That's true. We had someone in France working that project, getting everybody together on one page, speaking with one voice about information warfare from all the different perspectives that we were challenged with. The project was for us to develop a course that was going to cover 9 different modules. And those 9 different modules looked at all the different areas associated with nation state issues, as well as the history of information warfare. We looked at some of the challenges that would be presented to our government, our Congress. And so whenever Paul D'Souza releases that, I would definitely encourage people to go ahead and look at the product that we produced last year. He has things scheduled, and so it's good that he does things early on, but that the topic, content, subject matter, as well as working with a group that I'd never worked with before, we didn't know each other, being able to pull that off and pull it off well was one of my biggest achievements in my career, whether it was on a voluntary basis or not.
No, and speaking of, I think I was there in the beginning, I believe.
Mm-hmm.
It was a lot. I think for me, a lot of the content that I was privy to, because we had a lot of people that worked in pretty high levels of government in some of the 3-letter agencies,
Mm-hmm.
and what we're seeing now, I think, and I'm going to tie this back into the Ukraine and Russia,
Yes.
is what Jim Palumbo and I we had talked about before, with a gray zone escalation. Where do these things that are not necessarily military, the cyber warfare actually will evolve itself into boots on the ground type of situation. Mm-hmm. And we're seeing, and just a little bit that I've seen on the news anyway, seems like those attacks are the cyber attacks are increasing. Is there gonna cross a threshold at some point where this becomes somebody's hit a major critical infrastructure, electric power grid, something along that line, that's going to go, okay, we're not just going to fight back cyber. We're going to, start lobbing bombs literally over there. And I don't know if that was something if you agree with that, or based on the research that that we did. I mean, we did this for months and months on end.
Right. If you've been listening to alternative news sources, and maybe some of mainstream media, but mostly alternative news sources that have not been censored, if we're at the Defcon level associated with a potential nation state cyber attack coming from that direction over here, we're maybe about a Defcon 3.5. I think 4 is the highest, right? And so a lot of people are, all the things that we ask for people to do in information security and cybersecurity in terms of hardening their systems against a potential cyber attack. All of a sudden, everyone is running around and trying to do that because the war is real. What's happening between Russia and Ukraine is real. It's no longer gone from a conspiracy theory to being definitely a credible threat. Even though let's say that the president of Russia hasn't necessarily come out and stated that, there are other people that are close, very close to the situation, that have been saying this, that if something like this were to occur, this incursion right now that we're having between Ukraine and Russia, that we could expect a cybersecurity attack, and for that people need to be prepared for it. It's no longer something theoretical or hypothetical. It's something that is very real and could happen and has been threatened to occur during this incursion. So heads up to anyone who happens to be listening to this on this particular day. If you haven't started hardening your systems, it's better late than never, but you need to do it now.
No, and I totally agree with all those comments. And we had Chuck Brooks on. I'm not sure if you're familiar with Chuck Brooks or not, but big thinker in the space, and he believes that stuff like happened with Colonial Pipeline last year, and now you've got this situation now has really made this kind of a mainstream topic, because now you're looking at things that are targeting the typical person at home versus strategic government or universities or businesses that are at threat. It's starting to affect people in their houses, in their homes.
Well, we have a lot of soft targets over here.
Yep.
And, with me being in healthcare is definitely a soft target. Healthcare needs to be open for a variety of reasons in terms of sharing information back and forth between people. And unfortunately, in the process of having to be so open, it's very soft. Schools are soft targets. I'm hoping that our utilities are not soft targets. I'm hoping that they become as hardened as they can become. And there's no reason why there shouldn't be more funding allocated to make sure that our infrastructure over here does not suffer what the Colonial Pipeline people have suffered. The other thing that I wanted to mention, and because it just kind of came to my head while we were talking about this subject, the magician has you look at the hand over here while he's really doing something wrong. So, if we're just looking at Russia and Ukraine, right, we need to maybe kind of look over here a little bit at one of the countries that's notorious for nation state incidents. And it starts with a big C and ends with a big A. And, this is a good time while people are distracted over here for them to just come swooping in with some of the things that they typically do. And who's going to get the blame? Are we going to blame Russia? We're probably not going to blame Ukraine, but Russia will probably come up first because of all this back and forth and rhetoric and, what's going on, when actually we need to look at the big C and the big A people doing things, or, there's a couple of others that we could be looking at as well. But we need to keep a swivel on at all times right now, because the distraction is very real, and a distraction will cause us to not be on point where we need to be. So we need to keep on a 360 swivel.
In some of the video game I played, we called that third teaming. You're in that heavy firefight with the first team, and the third team comes out and knocks you out.
Yeah. That's right. That's exactly right.
So let's pivot. You mentioned healthcare. Let's get into kind of your area of expertise, what you've been doing. I believe 22 years with HIPAA regulations. Give us a little bit of your background. How did you get involved at this high of a level with HIPAA? Because it's been, I believe it became law in 1996.
1996 is when it was affected into law by President Clinton at that time. How did I get here? I laugh at myself. And that's a question that I ask myself on a regular basis because as a little girl, this is not what I thought that I was going to be doing. Uh, as a young woman, this is definitely not what I thought I was going to be doing. And as a pretty middle woman, professional woman, this is still not what I thought I was going to do. What I will say is I've enjoyed the journey. I've enjoyed the journey from going from a clinical background, research background, a patient care background, into healthcare information systems, where I learned about security, information security at that time, to going and working with different consulting firms, being a director with a couple of different companies. And then right after the Y2K initiative, of trying to make sure that no planes fell out of the air at midnight when we turned into the next century, being thrown immediately in 2000 into HIPAA. And so I remember I went to about 16 different conferences trying to figure out what this thing was, trying to make sure that it wasn't a hippopotamus that was being put on healthcare. And the hippopotamus is definitely what it turned out to be in terms of it being a mascot for HIPAA, and people misspelling it all the time and that type of thing. But I was fortunate to have very good mentors at that time. Bill Braithwaite was one of the authors of HIPAA, and he took me under his wing. During that time, and I was able to shadow him on many of those conferences and just have many talks with him. Another one was attorney Alan Goldberg, mentored me quite well from the attorney's perspective, because the attorneys, specifically when it came to the privacy portion of the regulation, really jumped on it at that time, because it moved from EDI to privacy to security. And so there was another gentleman by Tom Hanks that worked with me at Beacon Partners. And Tom hired me. And then about 8 weeks later, he left. He was considered one of the leaders, the futurist in HIPAA at that time, and had about 12 different presentations lined up for him to give. And what happened was, when he left, they put me in his spot. So 12 people were expecting this futurist to come along that they had been talking to years just in chat. And here I show up giving the presentation. So, that which doesn't kill you makes you stronger. And I was able to learn very quickly and come back and get back with people where I couldn't answer a question very quickly with them within the next 48 hours, and just have that level of discipline and rigor about this particular law. Now, it's morphed, as you know, over the years. The business associates in the beginning did not have to be compliant with regulation, only covered entities. And I mean, there is this whole issue about, what's a covered entity. And it's just, the law is very clear. It's very clear. It's people, providers, insurance companies, that type of thing. You have healthcare clearinghouses primarily. But it basically talks about those people that need to send information electronically. And we're talking about the claim from a healthcare encounter. People who send claims electronically to insurance companies electronically, as opposed to paper, those people have to be HIPAA compliant. It's no more than that. So people will always try to run around and figure out, well, do I have to be compliant? Do I have to be? Look at this little definition right here. Not that big. And the operative word of this definition is electronic. So if you do that, you have to do this. So then when the business associates coming along, especially when you look at the transcription area, where a lot of the transcription was going out of country, and where doctors would dictate, a procedure during the day, they would have somebody to transcribe it out of country at night. And then 7 o'clock the next morning, 6 o'clock the next morning, they would come in and everything's already typed out and ready for them. There was no way to hold those people accountable, right? Because they weren't in the U.S. should a breach occur out of the country. So that put in 2019 with the Omnibus Act, with the HIPAA High-Tech Act, when they made business associates accountable and having to be HIPAA compliant with at least the security and privacy rules. That changed a lot in terms of the perspective of, oh, I'm a business associate, I don't really have to do anything. Knock, knock. Yeah, now you do. And you're a business associate by another very small definition. You know, if you're receiving or doing something for or on the behalf of this covered entity up here that makes, with protected health information, that makes you a business associate. And so people laugh at me all the time because I'm maybe this walking encyclopedia of HIPAA.
We couldn't tell. I couldn't tell by listening to that.
Yes, I have to laugh at myself, but and I do. You know, I take my work very seriously, but I don't take myself very seriously. And yeah, but I've seen HIPAA weaponized. So, you know, over these years, where people in the hospitals or at the doctor's office or at the pharmacies or whatever will use HIPAA as this weapon. Like, no, I'm not going to give you this because HIPAA told me. Or HIPAA said. And I'm looking around for, you know, this sentient being that HIPAA has become. It's taken on a life of its own. Well, I can't do this because HIPAA said this. I can't do this. And it really, me being in the field and knowing that that's not true, at first I would try to correct people. And then I said, nah, let me just speak to your supervisor. Your supervisor's supervisor. You know, if we're going to have this little fight, I'm not going to have a fight with you. I'm not going to have a fight with a person that believes that HIPAA is a living, breathing soul.
So, let me preface my longer question based on how you answer it. Most of the places you're working with, are you working with? Clearly, it's like bigger organizations, bigger corporations in the medical industry, or larger hospitals versus the private practice areas, the smaller doctors.
Anybody who sends claims electronically.
So no, I mean you specifically.
Yeah, me. I've worked the gamut.
So how?
I'm mostly larger organizations though, but I've had some private clients where they're one doc shops. Yeah.
Sure. So one of the things that's been happening in the medical industry over the last several years is a mass consolidation. You know, there's a lot of private practices that are going out. The ones that are there have to tie into the into the larger hospital because, you know, they got to do surgery. So they got to, you know, electronically transmit, you know, to the surgery centers or to the main hospital to do work. How has that affected, enforcement, between the private doctors? Because I've went into some that literally they're not adhering to anything. And then I'm going, hold up, you're an entry point into the hospital. You've got all of this stuff tied into there. Mm-hmm. Do you think that this will kind of harden the systems up a little bit as we're getting consolidation? Has this been a problem transferring records around? How do you think that's affected the industry from a security standpoint with this mass consolidation as the larger companies are sucking them up?
Well, so it depends on how they're being acquired. If that smaller practice is being acquired and they're going to be considered employees of the larger organization, then the larger organization can go ahead and impose their expectations of policies and procedures, software, interfaces, HL7 standard mapping, et cetera, back and forth, you know, to the hospital or to the larger organization like a healthcare insurance company. If the smaller practices is still just going to be considered a contracted service to the hospital or to the ambulatory care surgery center or something like that, then they have no way of enforcing this person over here to make sure that they have their policies and procedures, that they've gone through their security, their privacy, that they've done their risk analysis per HIPAA. They can't do that unless they have it in their contract that you will be HIPAA compliant per 45 CFR parts 160, 164. I mean, it has to be the only way that the larger organization can enforce it upon the smaller organization is contractual. Okay. And so one of the things that the large organization needs to do as a part of their due diligence, if they're going to be working with this other entity, is to go in there and make sure that they have their policies and procedures, make sure that they've done their risk analysis, make sure that all their people have been trained. I mean, there's just some basic things that they need to do as a part of their due diligence during the contract phase. That's the only way that they can, they cannot dictate the EMR, EHR that these people are going to use over here. But
Sure.
what they can say is, in order for your information to come our way, it needs to come over here in this format. It can be, usually it's going to be HL7. Or if we're going to be going to the insurance companies, then it needs to be NCX 12, 50, and 5010. I believe 50, 50, and 50, 50 and 5010 are the new standards for the need to go back and forth if you're going to the insurance company. So there's ways that it can be enforced. It just depends on if this entity is a contractor or if the people over here have been grabbed and are now an employee of the large organization over here.
Oh, the reason I bring that up is because when we talk about security, we talk about supply chain issues all the time, and who your partners are, who your vendors are. And I'll tell you a story. I am obviously nowhere near as in depth with this, but this is an experience that I had several years ago. This practice has been bought out, but I was brought in to do an initial overall HIPAA assessment. And walking into I laugh a little bit just thinking about this. I walk into an environment where every piece of data, everything circumvented the firewall within the facility. It wasn't in place. And that the guest Wi-Fi, if you were sitting in the lobby, was on the same, basically the same network. You could access the server if you knew what you were doing, or sitting in the parking lot. Everything was totally accessible. And it happened to be tied into the hospital that was sitting in the same parking lot. And I didn't know, and I've been curious of if the hospital, for instance, knew about that. Would they sit there and go, hold up, we got to cut you off because you're putting us at risk from us maintaining our thing. So how does the enforcement work in a situation like that?
Well, it's constant polling and trolling in the background. I mean, if you have, if you're not logging events, if you're not logging events to your CCTV, if you're not having somebody look at the CCTV, if you're not looking and checking the logging events of people entering and where they're badging in and out, if you're not looking to see if people are carrying things in and out. I mean, like that's part of that's on the technical side of
Sure.
Some of it's on the physical side of the security rule in HIPAA. So it's just a matter of people, it's what I'm finding, John, is that people feel like it's a one and done type of deal. Okay.
Unfortunately, that's in unfortunately a lot of the industry. Cyber, we're there
right.
For the second, maybe.
Right. I've done it. It was painful. I don't feel like dealing with it anymore, but I've done it. And then an incident comes along, and then people wonder, well, how did that happen? Because I set up all these things in place to make sure that it didn't happen. Well, did you test it? Did you test what you implemented? Was what you implemented effective when you tested it? If you didn't test it, then that's why you had a problem. If you did test it and you found out that it wasn't effective, then why didn't you come up with another solution? And if you're supposed to have people monitoring these things, and they're not telling you, then you've got some problems there with people not reporting that there's an issue. That's why you go in and you saw all those things, but nobody's saying anything, probably because they think John's looking at it or Terry's looking at it, or Jimmy's supposed to be doing that over there, And then you get this, the story about when you point one finger out, you've got three fingers pointing back at yourself. And so it's just a matter of not adopting the mindset of that putting things together is one and done when it comes to security. That security has to be all monitored all the time, and that you need to look at it more than once a year. Even people say go ahead and look at your policies and procedures annually, but you need to look at your processes no less than every 90 days to make sure that they're working. I don't know how many times I have to talk to people about patch management.
Really? Okay.
Why is it that I'm having to talk to you about making sure that you've got the most up-to-date patches on whatever software or firmware that you're working with? And why is it that I need to talk to you about the fact that it probably needs to be done in sequence? When you patch, because you can't patch in, you haven't patched A, B, C, and D yet. So that
I was gonna clarify for people listening if they didn't know what that meant. Like, hold up, you haven't patched in 9 months. Don't start with the new one. And don't wait 9 months.
No, we're not trying to make a baby here.
No.
We're trying to keep safe, stay secure, and stay functional, stay operable. At any given time, we don't want to bring ourselves down. When we've got this fence and we're building all these firewalls, the last person that you want to implode your system is yourself or your organization.
Right. Do you find that a lot of people consider security it's a cost center, but now are you finding a lot of the organizations are they trying to just get by with the bare minimum, or are they really taking it seriously now with ransomware increases? Threat vectors are much more with the more devices. Your surface attack area is way broader than it used to be. Particularly, there's things in the medical industry that I don't think people even think about. We always think about your computers or your phones, but look at all the medical devices that may, they're probably, I'm gonna call them IoT devices, Internet of Things devices, for lack of a better term. But do you find that the hospitals really do make an effort at this, or is this just trying to get? And I use the term hospitals broadly. I didn't mean to.
Yeah, I understand.
But do you find that it really is the security of the information, the data, because there's a physical risk to here if something happens on top of just data leakage or people stealing data?
So what I would say is in healthcare, who has a tendency to be slow adopting certain things. Healthcare really needs to have very strong CTOs and CISOs, Chief Information Security Officers. When they have, at a minimum, a very strong Chief Information Security Officer that is very vocal, and I don't want to say a control freak or anything like that, but has developed those relationships in the organization where anything that comes in that may connect to the internet, I need to know about it. And please let me evaluate it so that I can keep it secure for either the organization or the patient that you're going to put this medical device into, that is going to be sending data back to their primary physician or back to the healthcare organization. Please let me be a part of that decision. When the CTO, CIO, the CISO, or whatever is not involved at that level, then you're going to have leakages occur across the organization, and all of that can be prevented if they are brought in early on in the decision-making process. They need to be a part of every panel of every medical device that's being brought in, whether the device is class 1, class 2, class 3 per FDA categorization, with class 3 being implantables. So my short answer to that is, the stronger those people are, and the more that the organization embraces bringing them into the decision-making process, the better everything is going to be in terms of securing the information that's going to be going back and forth between, because it could be hacked at any given time. And that's one of the issues that people are talking about in healthcare, particularly with medical devices that have RFID implanted into them,
Yep.
either, for tracking purposes, inventory purposes, or whatever. And particularly for those devices where, let's say, if you're looking at some of the devices that regulate pacemakers.
I was going to say, I know somebody that has a pacemaker, and that's what I immediately thought to when you said that.
Right.
Yep.
You're looking at pacemakers, you're looking at insulin pumps, you're looking at anesthesia types of devices where that information is being transmitted back to a clinician, and they're able to remotely titrate the information, titrate the dosage up or down, or with a pacemaker, regulate the pulses to the point where it's going to be best, for their patient. That's a man in the middle attack scenario right there, if they didn't involve security in taking in and bringing in that device and then putting it into a patient. To your earlier question, though, healthcare has become a little bit more sensitive when it comes to ransomware. To the point where some doctors have had to close their doors because they didn't have enough money to be able to pay the ransom to get to their medical records of their patients. That's very sad when those situations happen, and those situations are very preventable. But the healthcare clinicians and just practitioners in general need to understand that there's this whole security organization, society, people out here that you can go to and ask for help to have access to the information that someone is asking for a ransom for at this particular time. And you don't have to lose your livelihood. You don't have to recreate all that information over, but just ask, be willing to ask for help. So ransomware has become a number one issue within healthcare because there are so many ransomware attacks that have been happening in healthcare.
No, absolutely. And I used to see and reading articles and stuff for the places that were getting hit. A lot of them were not keeping their technology up to date. I mean, they were using systems that are well past end of life. You're hearing things of old versions of Windows still in place, and you're like, hold on a second. But I want to shift. I've got a HIPAA story, and I wanted to see what your response would be to this, because this happened to my mom. Okay. And I got a call in a panic, and I think this ties into if there's fear of people reporting an incident. Mm-hmm. But my mom was having some medical issues. They had moved, and she was going through this very long, arduous process of getting a copy of her records, to transfer from where they were going to where she had to go get seen. Right. After waiting 6 months, she logs into the portal. They had sent it, and there was somebody else's entire medical record attached to hers. And so I get a call in a panic. I'm like, you need to call the hospital. Let be upright that, hey, something happened, because she got hers as well. And come to find out that the other person's record was married to a doctor. And when they got wind of it, they weren't very happy about what had happened. But the HIPAA officers between the two different hospitals started kind of pointing fingers at each other. And I'm like, well, that's not either our problem. You didn't verify what you sent, and you didn't verify what you received. Correct. And my question with that, to them, the reason I told my mom to report it, I said, I don't know if that's a one-off or if that's systemic in their processes of what they're doing, that's happening 10% of the time, 15% of the time. If that situation scenario happened to you or someone close to you, how would you have responded to that? Putting you on the spot.
Having too much knowledge sometimes can get you in trouble, right?
That's why I'm asking.
Right. So in that scenario, the person who was at fault was the sender.
Okay.
All right. Not verifying the information first before they sent it, because in security is end to end, not point to point. Okay. So not verifying that information was just your mother's information, that was an issue there. somehow or another getting this other person's information attached to your mother's information and sending it out, you know, that's not something that probably happens a lot, but I could see where if you're not checking, doing a hash to make sure that just your mother's information went over and not your mother and somebody else's information went over, that's an integrity check that
Right.
obviously, wasn't in place there. So I don't care about the CSO and the CPO, Chief Security Officer, Chief Privacy Officer, whoever's trying to point fingers. The offender was the person who sent the information out. So it was not the receiver's responsibility to make sure that that was okay. It was not. Now, let's say that the receiver found it before your mother did. If the receiver found it before your mother did, they have an obligation to report it back and get it corrected before it gets to your mom.
Gotcha.
But, right. So, because something like that would happen so rarely, I could see why the receiver didn't do a check. And it came in with your mother's name. Okay, it could be this much, it could be this many, in terms of bits and bytes and that type of thing. And let's just send it on, because it's not something you would expect for the sender to have done the integrity checks on their end before it went out. But if there was, so now what are they going to do? Is the receiver always going to be in a position where they're going to have to check and see that the information is correct or not? It's not on them. It's on the sender. It starts there. So I don't know why it took 6 months. Because
military is involved. Military hospital is involved in that stuff. So that's what took so long. But yeah, no, she called me in a panic, and she gets like, I got this PDF, and it's all of my stuff, in an email, and then I go to the end, and it's another patient's entire record, and it was just I had not heard of that, and I didn't know if it was like the electronic medical records system messed up, or somebody legitimately on that first end at the first hospital just scanned something into the wrong way. But I found that to be interesting.
It could be system error, and it could be human error. But an error was made.
For sure.
And I'm glad that your mother brought that to your attention, because another person, could have taken that and said, hey, look, what I got? I got my medical record, and I got somebody else's, just like their 15 minutes of fame on TV with a reporter and, news people around.
Oh, yeah.
But I'm glad that your mother had enough wherewithal to know that this was wrong, and just take it to you, and kind of let people work it out internally. Because when we get off of here, there's a page that is sponsored by the Department of Health and Human Services of every breach by every entity that has come to their attention that they make public.
Okay.
Yeah, I call it the HIPAA wall of shame, or most industry call it the HIPAA wall of shame. It has the entity's name, how many people were affected, what was the cause, and who did it. and usually it's
this is why people don't want to report.
This is what people don't want to report. If 500 people or more were affected by the breach, you can go out there anytime you want to and look and see who's doing what. And this, speaks to the credibility and the reputation of the organization with regards to their security processes or lack thereof.
Yeah, and that sometimes, at least with a little bit of my personal philosophy, mistakes are going to happen, particularly if there's a human element involved. The most rigorous process, sure, there being a technical control in place to prevent you from doing something most like you're tired, you're not paying attention, you're doing 19 things because you're doing the job of 3 people. An accident's going to happen. But transparency without repudiation, sometimes I think, short of it being egregious, like you said, 500 people, that needs to be out there.
It needs to be out there.
I wanted to
Yeah.
go ahead.
Side-eyed at these people too.
Yeah.
I mean, because it's 2022. It's
Yeah.
2022. This law has been in place since 1996.
96.
And the security regulation has been in place since 204, 205. And we're still having these issues in
Yeah.
2022. Do you see what I'm saying? So it's
Oh,
not,
absolutely.
oh, we're still getting around to it. Oh, we're all, we were going to work on that.
You know how it
Uh,
is. You ain't done it by now. You're not doing it.
where have you been? Where have you been?
But I'd be remiss with to not ask. I do not know what this is involved about COVID and the privacy stuff. And you had worked in, I know you said Baltimore and public schools with some auditing. Can you explain a little bit of what specifically you were doing that was COVID related in the school systems?
This is interesting. So I'm able to use my audit and assessment experience in another way and push up my auditing and assessment experience and use it for COVID. And a situation here with this 72 72 schools where they were trying to get the children back to school, as opposed to having them, take their lessons and do everything on a virtual basis. So this was part of the COVID initiative, getting back to school face to face. So you need to look. What I did was normally, in security, we're looking at standards like NIST or ISO or whatever. Here, there's a group of standards that have been put in place by the school system, and coming from the CDC, coming from OSHA, and some of the things that have been published by FDA about what people needed to have in place in order for children and the teachers and other staff members of the school to be safe when they came back to school. So we looked at hand sanitizer, the percent of alcohol in the hand sanitizer, if they were wearing masks, if they had signs up that said stand 6 feet apart, if they were on the floor and they were actually 6 feet apart, if they were on the walls and they were actually 6 feet apart. Looking at signs near the elevators that said no more than so many people could be in the escalator at any given time, and then looking in the elevators, and seeing that there were signs in there that said 6 feet apart. Making sure that there were partitions in the various places where they were going to have people come through. Looking at people and how they were keeping their records associated with temperature taking as the children came into school and as the staff came into school. And if they exceeded their threshold, which I think was 99 degrees Fahrenheit at the time, because they had dropped it from like 100 or at that time. If anybody presented that way, how were they going to take that child and isolate them in a room until their parents could come and get them, or arrangements could be made for them, the child to be taken and to go home, for them to go and get COVID tests, to get a doctor's release before they could come back to school. Same thing with all of the staff that was in the hospital. So there was this list of things that they expected for these 72 schools to do. And myself and 4 other auditors did the audits for those schools and came back with a report to say how many were in compliance, how many were not in compliance, and what the remediation pieces that needed to be done per school, and then overall. Yeah, so that's what we were doing with that particular project. With Baltimore City Health Department, I was asked to come up because of my certification with the Department of Homeland Security to help them with their recovery planning, because the pandemic is considered a national disaster, government disaster, and it falls under the definitions of Homeland Security with their disaster FEMA protocols. So I was working with them on their recovery plans for a while until it became very apparent that recovery planning was a little bit too early to initiate because Delta and Omicron came along.
Of course.
So, yeah. So the other people on the team were able to stay. I was asked to stand down until they come up with a time where they're going to be doing recovery. Maybe I'll go back to that. But it was very interesting looking at it from the perspective of a city department and then the overall department of the state of Maryland, how they were working together with Baltimore City and how the state was working with their initiatives, and then looking at the counties, because people don't realize the cities are responsible for their own plans, the counties are responsible for their plans, and the state is responsible for their plans
Yeah.
coming down from the feds. All right. So you want to harmonize all of these plans together for any type of incident, for any type of disaster, but they can be written in silos. And so
That happened in Virginia.
right, right. And so when you're coming up with these emergency plans, it would be nice if you could have everybody together. And
Need some more tabletop exercises, it sounds like, that happens around this.
more tabletop talking, Starbucks, whatever it takes to get people together. So, I mean, because that's one of the things that's coming out of this whole pandemic is people did pandemic planning back in 2009, 2010 for that, but then they left it alone. So then they hadn't looked at their pandemic plan for years. So then this one comes along, and this one is a worldwide pandemic.
Right.
So there's a lot of more moving parts that went along with this pandemic than it did with the one for 2009 to 2010. So many of the things that we have to look at for COVID in terms of preparation and going forward, because some people COVID is not over. People feel like it's over, and everybody's kind of COVID weary. Even the planners are COVID weary. But we're not at the point where we can just throw everything away and say, we declare that the pandemic is over.
That sounds like Michael Scott. Remember from The Office? I declare bankruptcy.
Right, exactly. So you got these human beings running around saying, we're tired. We're declaring that this pandemic is over. It's not an emergency anymore. And the virus is going to say, well, let's see about that. We can't necessarily. We can maybe scale down the emergency response, but we still need to be on our P's and Q's when it comes to maybe learning to live with it, like we have done with influenza. So that you're right, it becomes more of an endemic type of process as opposed to this big emergency, this big pandemic type of issue.
Right.
So the story is still out on that. It hasn't been closed yet.
Well, awesome. Well, I greatly appreciate your time. I clearly know who, if I have HIPAA questions, who I'm going to first, and who anybody listening to this needs to go to first, unquestionably. If anybody wants to, reach out, inquire how to work with you, follow you, what's the best way for them to do that?
They can reach me at info@ingramandassociates.com, and that's Ingram, my last name, and then a little n for A&D, so it's a little n, associates.com. They can look at my website at www.ingramandassociates.com, or you can find me on LinkedIn by my first and last name, Sybil Ingram.
And I will make sure to have those links in the show notes for sure. And again, I really appreciate time. This has been fun. It's been enlightening. And I can't thank you enough for spending the last hour with me.
Well, regulations doesn't have to be boring. And
no.
A lot of people think
maybe.
Kind of, right. Yeah, well, it depends on who's presenting. If they're boring, then it's going to be boring. I don't consider myself boring. And I mean, it's a lot of this is just kind of common sense type of stuff. But you learn over the years the more technical aspects of it and how to present it. I know the lawyers started talking about HIPAA being healthy income paying prepared attorneys. And so that's what HIPAA stood for them. And or paying aware attorneys. And so they would make some jokes about it. But I can talk about this anytime. And I can talk
Awesome.
about other things too, John.
Yeah. We'll have to figure that out for another episode then.
Okay. Well,
Thanks
thank you
again.
for having me. I really appreciate it. And
Yeah.
again, I'm not blushing as much right now, but I'm still very flattered and very honored. This is a privilege for me to do this for you, and I'm willing to do it anytime.
I appreciate it.